take a peek at the agenda here. Again, I'm Jen Kovich-Bordenick. We're going to hear from John Larson here shortly from Booz Allen Hamilton. And Booz has been great, an incredible supporter, I think, of this program, and has helped us identify some really great examples from across the industry that we're going to be sharing with you today. So I want to thank them for their support of the program. We're going to see a really cool simulation, which we'll get to briefly after this. We've got Lauren Neal, Brian Albert, Amir, and Cameron who are going to be sharing that with us today. You go to the next slide there. There you go. Then we're going to see a medical procedure demand modeling tool. This is really cool stuff. We've got another great example from Counterpoint Solutions, Contagion, which I think is such a smart name. Really excited to see that. Really neat way to look at analytics there as well. NVIDIA has a really cool response tool as well. And then we'll end with this forecasting COVID-19 and mobility data. A really neat way to track COVID-19 in the workplace and kind of where people are at with COVID and where they've been, and just, it's a very cool tool. So welcome to the session today. For those of you who aren't familiar with the eHealth Initiative, I just want to run through a couple of quick slides. eHealth Initiative is a nonprofit here in Washington, D.C. We do research, education, and advocacy. If we go to the next slide there. Thanks. And keep going, next slide. And we're made up of really, I think, some of the most influential companies in healthcare and technology. This is just a sampling of our leadership. And what we really pride ourselves on is convening leaders and executives from across all different parts of the spectrum of healthcare. We think it's really important to have everybody at the table, and that's why we've got such a diverse group here today. Hospitals, health plans, vendors, researchers, all different folks so they can all sit down together. Healthcare is very interconnected, and we want to make sure we bring all the executives together, which is an example of what we've done here today. Next slide. So, can you go to the next slide? Thank you. So these are the areas that we work on currently: privacy, telehealth reimbursement, information sharing, analytics, and of course, addressing COVID-19. And we've spent a lot of time in the last 6 months looking at how innovation and analytics can be used to address a lot of the challenges we're facing right now with COVID-19. Next slide. This is just an example of some of the recent forums and webinars that we have held with executives. We've been looking at remote monitoring, we've been looking at telehealth, population health, all different ways to address the challenges right now that we're facing. And all this information is available on our website, which is ehidc.org. And I want to encourage all of you, you can access any of these programs there, share them with friends, collaborators. Please, that's what we're here for. Again, we're trying to fulfill our mission of helping connect technology and healthcare. Next slide. And also give you a heads up, we've got a number of reports and research that's coming out soon. We just recently released a report on social determinants of health. We have a survey report coming out next week looking at interoperability and how people are functioning and getting ready for the new interoperability rule. And we also have a report coming out next week looking at Native Americans and how they're using innovation to combat COVID-19. So some things to keep your eyes and keep on the lookout for next week. Next slide. And I want to turn it over to John Larson really quick. And again, thank Booz for really supporting this program and helping pull this all together. I think what you're going to see today is really fascinating and definitely worth your.
Great. Thank you, Jen. I appreciate that. And thanks to the entire eHealth Initiative team. What a great event to be able to participate in. And we're just excited to have the incredible talent that's here today. Really love the vision of the cross-pollinating aspect of this. We are clearly in some extremely trying times. And I think the ability to have an impact for the greater good has rarely been so measurable, right? And I think we're at this interesting nexus of the role of data and analytics and AI and how it can help in combating COVID. It's a really interesting time to be in this position. And we're witnessing, I think, one of the largest global pandemics, right, during the dawn of what is the ascendancy of the AI age. And AI is proving to be, I think, a vital tool for addressing the challenges that healthcare workers, researchers are facing during this pandemic. And these AI technologies they've been operationalized to combat COVID-19 in an array of ways, from drug discovery and really accelerating that, to patient triage and screening, to the intricacies of contact tracing and using things like phone apps and Fitbits and other types of devices to do real granular contact tracing, to social distance monitoring and measuring, and modeling disease spread and impact, right? All of these things are being unlocked and made possible by the rise of data, the rise of compute power, and the rise of algorithms to really do that. And so we hope this event will serve that goal that you outlined, Jen, which is to really allow us to exchange ideas, to talk about how those ideas, the technology and innovation that our presenters put forward today are really going to change the way health workers, researchers, public health officials are going to expedite the end of this crisis. And this is something that's core to Booz Allen and our mission, right? We have a real heart for this. We've been supporting numerous clients around this initiative within the federal government. So at the CDC, around their Decipher platform, we are one of the team that really support through the engineering and data scientists to design the critical data pipelines and the integration of new data sources and development of public-facing dashboards to enable the CDC and the response task force. We're also working very closely with the Defense Health Agency around deploying models to project the impact of COVID on military treatment facilities. Critical mission for our military, the military family members and military employees. And then with the US Air Force, we're using publicly available COVID-19 data to address open scientific questions about COVID-19 transmissibility and virulence, and how we can support research and the mitigation strategies that the public should be embarking on. So we're very close to this mission, I think, with many of our clients, but we're also really taking important steps to empower our people. One of the things we talk about at Booz Allen is how we empower our people to change the world. And so we've made substantial commitments during this crisis to really focus on how we make investments towards that goal and objective. We see this opportunity to help change the world by bringing solutions to this problem set. And one of the things we did was we partnered with our Booz Allen Foundation. We committed $10 million in assistance to our communities, where we were providing assistance in grants and donation and volunteer hours, pro bono work, and technology to help families, military families, veterans, frontline healthcare workers, and those who are most vulnerable to the virus, including the elderly and the homeless. So that's one of the ways that we've been really committed to this. The other one is we invest in bringing our capabilities and expertise to this problem set. And that's part of what we're going to share with you all today, is we have been focused on developing a COVID-19 safe return simulator, which predicts when a given locality, and that's one of the keys here, is this granular nature of this, which predicts when this given locality will be safe to consider reopening and evaluate those strategies for reopening based on a variety of key metrics. So that's what we'll be talking about here, is this introduction of this new capability that combines, I think, traditional proven epidemiological modeling methodologies with some of today's more sophisticated forecasting techniques to predict when communities are projected to be at that low risk at the county by county level, which is so exciting. So the team that's going to present and talk about this today will be Dr. Lauren Neal, Dr. Amir Mukhtari, Cameron Minio, and Brian Albert. And they're going to walk through this solution that we've developed, sort of why we think it's relevant, how it's important, and some of the underlying methodologies behind it. So with that, I think I'm going to turn it over to Brian, who's going to start by walking us through the solution we've built. So Brian, off to you.
Thanks very much, John. I really appreciate it. Can everyone hear me? I know I was having some audio issues earlier.
Yes, you can.
Excellent. Okay. So thanks very much, John. Again, my name is Brian Albert. I work in SIG Analytics, our strategic innovation group, and I focus on our persuasive analytics storytelling work here for Booz Allen Hamilton. And I am part of the team that helped develop the COVID-19 Safe Return Simulator that we're going to brief out to you all and talk through some of the lessons that we learned and how we put it all together. And we're really excited about this. As John mentioned, this is something that we wanted to do for the members of our community and put it out there. And so we're really excited about being able to help contribute to solving this for everyone. So what we'll talk about here briefly, just the agenda. We'll talk about the problem, the solution, the data sources and challenges we have there, some use cases and customization ideas that we've gone through, and then we'll talk through some of our key takeaways, really our lessons learned from the whole process. So first, the problem. So one of the things that when we first started looking at the COVID-19 issue that was presented with all of our decision makers is that they didn't know when it was going to be safe to begin initial reopening and when risks were going to be low. And so despite an abundance of available forecasting models and tools that were out there, none of them were helping localized decision makers get the answers that they needed. So the COVID-19 pandemic flooded decision makers with data and statistics, models, forecasts, and graphs, but no real actionable information. There were some forecasts that were available, but they tended to be at the state level or even the national level, which is not very helpful in more localized situations, particularly when the nature of the disease spread can vary so dramatically within states and even within counties. And finally, there were some tools out there that were indicating how a state or a county might be doing relative to risk criteria, like the spread of the disease or the number of cases, but they only ever provided the current status. And none of them gave any sort of clear indication as to when a particular location might be projected to meet those risk metrics. And so what we put together, or what we decided to put together, was something that combined both localized forecasting at a highly granular level with those risk metrics that tell you how a particular county is doing in order to provide a very actionable low-risk date, which is the date when each location is projected to meet the requirements for a series of key metrics. And that way, localized decision makers could be confident that their areas have sufficiently reduced the risk in those localized areas. And so that was the problem, and the solution we came up with was the Booz Allen COVID-19 Safe Return Simulator. So what I'm going to do is share that with you right now. It is a public website that you can all go to, and I encourage you to do so, covidsimulator.boozallen.com. And this is the landing page that you will come to. And so right now we are projecting, we have forecasts projected for all 50 states and every county. I think there's 3,000 some odd counties in the country. And so this is our landing page where you can select the different states that you want to look at, either from the map or from our drop-down, and an overview of sort of what our challenge was, how it works, and some additional resources here as well that you can all look through. But I think what you all are most interested in is sort of seeing how the tool itself works. So what we can do is start to look at a particular state. You'll note that we have our overall projections nationwide. Right now we're projecting through the end of the year. We found that about 3 months out is where we're most confident in our projections. And so you can see what our current overall projections are for cases and deaths nationwide. But then we can start to look more detailed. So if we look at a particular state, for instance, Virginia. And here what you'll see is that we have a low risk score for each county, or in Virginia's case, there are some cities. And the way that it works is if a county is yellow, that means that it has already reached its projected low risk date, right? There's still, the virus might still be spreading at low levels within those counties, right? It's not completely gone, but it's at a low risk as measured by some of these metrics that we'll get into in a second. Orange is orange counties are at an elevated risk, meaning that they will reach their projected low risk date within the next 3 weeks. And red counties are ones that are not projected to reach their low risk date within the next 3 weeks. And so that's the initial dividing line that we have for how we're establishing the risk level for each of these different counties and cities. And we also have our statewide totals in terms of our projections for cases and deaths here. And so you can see we have our actuals going up through today, and then our projections for Virginia were last updated on September 30th, and we have our low, medium, and high projections here moving out through the end of the year. If we look more closely, because the real benefit of this tool is looking at the localized level, at the county level. And so we can look, for instance, at a particular example. Again, you can scroll through the different counties, or you can click on the map. So if we wanted to, we could look at say, Richmond City. And the reason that I chose Richmond to look at, I'll get to in a second, but I want to show you each of these different metrics that we're using in order to determine the low risk date, which, as you can see for Richmond City, September 30th has already passed. So we're looking at 5 key metrics here. And these were derived largely from New York State's initial localized guidance. We used that as a benchmark for our initial product. And then, but it is completely customizable and tailorable if there are different benchmarks or metrics that need to be used depending on the needs. But for these benchmarks and metrics, we have, the first one is a decline in daily deaths. We're looking for a 14-day sustained decline in daily deaths, or, which is the case here, less than 5 deaths per day for a sustained period of time, in which case it's not applicable. The next one we're looking for is hospital occupancy, which would be a 14-day sustained decline in the current hospitalizations. The next one is new hospital admissions per 100K. So we're looking for less than 2 new hospital admissions per day per 100,000 people for the duration of the forecast period. The next one is hospital utilization. We're looking for at least we're looking for no more than 70% capacity, right? At least 30% of hospital beds are available in order to accommodate any potential incoming surge in patients. And then similarly, ICU utilization. We want to see at least 30% of ICU beds available in order for a county to be considered low risk. And so those are each of the 5 primary metrics that we're looking for. And once a county has met all of those metrics, which as you can see, Richmond City here has, then we consider it to be low risk. And so you can also look at each of these metrics as they show over time. So as you can see, the deaths are below that 5 threshold. So that is already met. Hospital occupancy, as you can see here, we are projecting steady declines in hospital occupancy in Richmond City throughout the duration of the forecasting period. New admissions is below that 2 per 100,000 metric that we talked about, and is projected to remain below there for our low, medium, and high projections. Hospital utilization and ICU utilization both well below that 70% threshold. The one that is probably most notable, right, is cases, which as you can see, these are our actuals up through today, and then our projected forecasts for Richmond City moving forward. So the reason that I chose Richmond to look at here is that there's lots of potential uses for this tool. In addition to county officials or county health officials, there's a lot of uses for federal government agencies, for instance, VA. Right, so if we're looking at Richmond City, where Hunter Holmes McGuire VA Medical Center is, we can see that it is currently at and is projected to remain at low risk, meaning that particular facility, that particular hospital, Hunter Holmes McGuire, is probably well positioned to continue operations or potentially even offer up additional services if needed. And we can be confident that they're projected to remain that way because we've overlaid these metrics with that longer-term forecasting out through the end of the year. Another thing that's really important about our tool and that we think is really unique is the localized nature of it. And as opposed to looking at how individual states are doing as a whole, you can see just from the map here that different counties have all sorts of different low-risk dates. And so if we look at another example, let's say we go over to Roanoke County over here, which is where, again, using the VA example where Salem VA Medical Center is, you can see that Roanoke County is not projected to meet its low-risk date until after the end of the year, at the end of our forecasting period. And so we can dive a little bit into why that's the case. So again, as you can see here, NA, the daily deaths, are below that 5 per day. So that particular metric is not applicable in this case. Hospital occupancy, it's hovering about the same, starting to creep up a little bit according to our projections until around the middle of December, where it then starts to level off and drop again, which is why the hospital occupancy date is December 9th. But the real issue here is projected new admissions. And so for Roanoke County, you can see that we're projecting around 3 to 4 new admissions per 100,000 people pretty steadily throughout the duration of the forecast period, which is well above that metric we're looking for of 2 new admissions per 100,000 people. And so we're not confident giving Roanoke County a low risk grade until we start to see some of those forecast numbers come down a little bit. And so in the case of the VA, again, for example, this might be a situation where the VA can look at this and look at Salem Medical Center and want to take actions to expect some potential increases in cases there, or increases in patient need, or offering up the opportunity to work with or provide services to local civilian hospital centers that might be expecting increases cases as well. And so that goes to show some of the value of being able to really look at these localized forecasts as opposed to something at the statewide level, and being able to overlay them with the different metrics that we're looking at here. And so that sort of wraps up, at least for now, the demo of the tool itself. Like I said, I encourage you, please go to the site, play around with it, look at different states and counties, and give us feedback. I'll give you some information at the end about how you can do that. But we're really excited about the benefits that this tool can provide, both to the general public and also to a lot of our colleagues and clients throughout the federal government. So I will come back now over to the deck itself to continue on talking through it. So that was the solution. So our data sources and challenges, right? What goes into the model that and the forecast that we've put together? So first, a quick bit of background, some epidemiological forecasting 101, which I'm sure is fairly well known to all of you. But just very quickly, there are 2 general types of epidemiological forecasting models. There's a statistical or curve fitting model, which tries to fit a line based on some of the observed data, and it's really best used for forecasting and resource allocation in the near term. Some of its shortfalls are that it's not really well suited for long-term projections because they don't account for underlying disease dynamics or changing behaviors. And so the original versions of the IHME model, which is one of the obviously more commonly used and cited models, fall into this category where they built the shape of the curve around some of that early data they were seeing in China and Italy. The other main type of model that we'll see are systems dynamics models, SEER models, SEIR models more commonly described as, where they mimic the way the virus spreads, and they incorporate a lot of the disease-specific parameters like transmission rates and recovery time, hospitalization rates, so that you can test how the pandemic might change under these various assumptions. And one of the main shortfalls here with these types of models is that they tend to apply the same types of disease parameters to everyone across the entire population, which, as we all well know through our recent experiences with COVID-19, is definitely not the case, right? The disease has different susceptibility rates, different mortality rates, depending on who the population is and what any of their underlying conditions might be. So what's different about the model that we used and that we built and put together? The first is that we've incorporated a lot of underlying data, population data, chronic condition data, observed cases and deaths, socioeconomic data, and we even have the ability to incorporate in real-time telemetry data that we've built into the process. And so we take all of that and then put it into our simulator framework. And so what we do is we start with a highly modified SEER model. So instead of just having susceptible, exposed, infected, and removed, we've expanded that out to have 4 different levels of infected. We have infected asymptomatic, infected mild, infected severe, and infected critical. And then we've broken out the removed category to include recovered and deceased. And so we have a highly modified SEER model framework that we're starting with. And then what we do is, if we start at the individual state level and zoom in on a particular county, what we've done is we've taken county level data for each state and broken it into 5 different age cohorts. So as you can see, we have 0 to 17 and 18 to 46, 46 to 64, 65 to 74, and 75 plus. So we have our 5 different age cohorts within each county, within each state, because we know that the disease is impacted by and has different disease parameters for each of these different groups of individuals, even within an individual county, right? And so looking at the data layers that I mentioned that we're carrying over, we're looking at the chronic condition data at the county level. We're looking at things like the behavioral, the BRFIS, and the CDC's social vulnerability index data, all at the county level, and then further breaking down into individual age cohorts. And what we've done is actually created a separate individual SEER model for each age cohort for each county across the country. And all of those SEER models are then interconnected. And so in the case of New York, for instance, which has 61, I believe, counties, we have 5 different models for each county. So it's 300 and some odd number. Math is not my strong suit. 300 and some odd individual interconnected SEER models for just for the state of New York, where we're looking at how the different dynamics are interplaying among the different cohorts within each of those counties. And then what we have is the ability to create and test different scenarios and provide lots of different outputs for each of those models. So we have those outputs include the projected safe to reopen dates for each county, the number of infected individuals by age cohort in each county and state, the number of hospitalized, number of ICU admitted, number of deaths, and then the hospital utilization rates, ICU utilization rates, and the infection growth rates for each state and county. And so all of that, it's the highly sophisticated model that we build is what's underpinning all of these projections that we put together. So some use cases and customization that we have for this tool. There are lots of different opportunities to use this tool. The primary one, and one of the reasons we put it out publicly, is for city and county governments, so they can understand the localized spread of the disease and its impact to their populations, and also what the projections look like for their populations, right? Are they in a location where the given dynamics of their populations make it likely that the disease is likely to spread, or that they're, starting to see it diminish and that the risk levels are starting to get lower. We've also spent a lot of time talking with military facilities, base managers, facility managers, so that they can start to think about when the localized risk in their area is such that they can begin to bring back some of their staff members and service members based on the risk in the communities in and around their bases and their facilities. And then we've also had discussions with university leadership where they can start to think about, at an even more granular, more localized level, how are they going to bring students back, and where are they coming from? What do the risk levels look like in terms of where they're coming from? And then if we start to incorporate some of those real-time telemetry options that we've been exploring and that the tool is built to be able to ingest, how can they use that on an ongoing basis for their student and faculty populations when they do decide to return to campus? Some customization opportunities that we've looked at. We've talked with the Department of Defense in particular and some of the agencies within DoD about different ways that we might customize this tool for their needs. Rather than having, for example, one particular low-risk date, we could set up something like you see here, where we project out to the 5 different gating criteria that DoD has decided upon, right, where there are different policies in place, different criteria that need to be met in order to move from 0 to 1 to Alpha, Bravo, Charlie, et cetera, for each of the different phases of their reopening schedules. And so there's lots of different ways that we can customize this tool now that we have the framework and initial structure built out already. So some lessons learned as we were going through this process and making it available publicly, and some things that might be worth thinking about for you all. So the first is, we spent a lot of time thinking about how we can improve the fidelity of our model. And so the first thing that I would say that would really help the most in terms of improving our model fidelity is having more details on the historical cases and deaths, right? What are the ages of those patients and the underlying conditions, comorbidities, things like that. All of that, if we could gather and have access to that historical data, would really help increase the fidelity of our future forecasting by significant measures. The next one would be better understanding of population movements within counties, across counties. You know, to what extent are individuals adhering to social distancing guidelines in their localized areas? All of this would help us to better fine-tune those RE, those expected R values within the individual county levels as we're projecting moving forward. And then the last one would be focused on model optimization and operationalization. So right now, the way that our model works is we optimize at the state level, because as you saw with hundreds and hundreds of different models to simulate for each state, optimizing at the state level was really the only way that we could make it work from a computational standpoint. But we would like to ideally optimize at the county level. That just requires significantly larger computational requirements. And so that's a consideration it's a factor to be considered that we've learned a little bit about as we've gone forward. Then the next piece, in addition to improving model fidelity, is the source data. And this, I'm sure, does not come as a surprise to anyone here, that it makes it very difficult when different states and counties report their cases or deaths differently in terms of how they define them, the timing of when they announce them, the frequency, how often they're reporting their data, how to access it and gather it, not even taking into account the potential data errors or accuracy of the data itself, right? And this becomes a huge challenge in terms of trying to build a national tool such as this that can be used at really localized levels. And the other challenge in terms of source data is standardized data on hospital usage and capacity. So we use data from the American Hospital Association as our underlying data for the number of hospital beds in each county, the number of ICU beds in each county. But there are lots of changing dynamics and changing factors as different locations start to set up surge facilities that can accommodate more capacity and things like that, or they're shifting within their hospitals to create additional ICU capacity that they didn't have previously. And then the numbers of patients in a particular hospital are also, it's difficult to find standardized data on things like that, particularly at the county level. So those are some things that are worth thinking about and taking note of in terms of how we can improve products like this for the betterment of the localized decision makers who are using them. So with that, I will say thank you very much. We have an email address here that you can reach out to us on if you have questions about the tool itself, or as you're going through and playing around with it, we'd love to hear from you. But I think we also have some time for some Q&A right now. So I'll just leave this screen up for the moment.
Yeah, great. This is fantastic. Really interesting. So I know we have a couple of questions here. So let me go through these quickly. And if there are other folks who have questions, feel free to unmute yourself as well, or show us your face on video and raise your hand and we will get to you. Question here about whether or not using ED data might be helpful here. Have you guys thought about putting emergency room data into the simulator?
Yeah, so let me, I will actually turn it over to Cameron Mineo, who's our lead modeler, and I'll let you take that one, Cameron, if you want to speak to that.
Great.
Yeah, certainly. ED primary complaint data is going to be very difficult to come by, specifically at a county level. Additionally, what you saw in that demo is projected hospitalizations as well as ICU admittances. And those projections are essentially derivative of the disease spread, the number of cases in the county. We calculate the hospitalization rate by age cohort from CDC data using approximate infections and hospitalizations. So that's how we project it. If we were able to obtain specific county level actual, ED primary complaints that turn into potential COVID diagnoses, I believe we could probably put it into the model, but we just don't have access to that right now.
Okay, great. And then the other thing that was a question came up here in the chat box. Teresa Gerard asked about the, does the model consider mandatory rules like masks, wearing masks or closings in a county, which I'm sure impacts the rate as well?
Sure.
Yeah, oh, sorry, go ahead, Cameron.
Yeah, so this looks like actually a two-part question. So the first part of it is diversity of population within a county in addition to age. We have the demographic information available to us right now. However, it currently is not incorporated in terms of, like percentage Hispanic or something like that. I'm assuming is what you're asking in that question, but it could be if we were able to understand a little bit better about how those populations were affected in terms of, critical cases, hospitalizations, et cetera. In terms of mandatory mask rules or closings in a county, we have the ability in our model to perform what-if analyses where we can use assumptions in order to, say, for example, what if we totally shut it down, like we closed all businesses, right? How would that look in terms of disease spread versus what kind of, if we kept our current restrictions? Projections you see on the website are simply one set of those projections, which is what current restrictions are, which we believe is encapsulated in our projected effective reproductive number, which we use, we create using Markov chain modeling and then feed into the model.
And then there's an add-on question here also from Kenneth to Teresa's. Does it consider proxy measures of adherence to mitigation? Mobility of individuals during closing, mobile device data. We're going to talk about that a little bit later, actually. As mask adherence is more difficult to ascertain. And then another social determinant of transition risk may be a locality's predominance of business types. So any thoughts on that, Cameron?
Certainly. So that was actually one of the kind of additional data sources that we would like to get more insight into that we listed on previous slide, was understanding how mobility works and how we could potentially ascertain adherence to social distancing regulations. Right now that there is mobility data out and we have looked into it, but it's been difficult to kind of map it to understand how people are adhering to these strategies. Additionally, cross-county movement is something that we would really like to incorporate, but comes with a little bit more mystery surrounding it. All in all, though, we believe it's a great idea, and we would like to try to continue down that path if given the opportunity.
Yeah, one of the challenges, just sort of combining those two factors, the social mobility data and then also adherence to social distancing guidelines, right, is that even when you have telemetry data at a very granular level, right, you won't necessarily know if two dots on a map, if they're within 6 feet of each other, you don't know if they're facing each other or not, right, and which can have significant impacts. So you don't know if they're wearing a mask or not. So it becomes very difficult. And as Cameron mentioned, we looked into a lot of this. We partnered with Mapbox to look at telemetry data at highly granular levels and found that the predictive capability was not all that strong, frankly, because of some of these factors and variables that are difficult to control for. But it's something we're continuing to look into, and hopefully we can start to work some of it out.
Can you talk a little bit about some of your data sources? Are these coming directly from the state or from public health, and how often are they updated?
So the primary data source that we use for training our model that is updated continuously is from USA Facts. USA Facts is a great data source that aggregates number of COVID-19 cases and deaths at the county level for every single county in the United States and updates it on a daily basis. This data is pulled in from a wide variety of sources such as state governments, local governments. So they're kind of the premier source for day-by-day cases and deaths. In terms of demographics, right, so age groups, population, et cetera. We have that from CDC as well as census, and then of course, like I mentioned before, hospitalizations over time we get, and by age group we get that from CDC as well. Brian, did I miss any?
No, I think you covered it. Yeah.
Okay, let's get some other questions going here, guys. If you want to pop on your video camera so we can look at you, that would be great as well. It's not as fun to look at everybody's names, but we'd love to see your faces. So even if you don't want to ask a question, just show us your face, would be great. So tell us a little bit, you mentioned a couple of places that have asked you to customize the model. Can you talk a little bit more about kind of how it's being used right now by different employers and governments?
Yeah, so we're still in discussions with a couple of different agencies for how they might be able to utilize and customize it. As I mentioned, we've had a few conversations with the VA. We've talked with CDC. We've talked with some folks throughout the Army in particular about using it with bases, and we've talked to a couple of universities. At this point, we're still trying to figure out the best ways that we might be able to customize or utilize, be able to customize it for them so they can utilize it. But I think one of the benefits of how we've designed it is that it is very, very easy to tailor and customize. So for instance, for the particular metrics and criteria that we've set up, it is a very quick turn to change what those metrics might be. Based on different policy guidance from your agency or department, or from your, at the localized level, wherever your county or state reopening metrics might be, changing those is very easy to do. And adding in different features and functionality, like, for instance, redrawing the lines so that they're not at the county level, but maybe they're at, the regional level for your agency or things like that, right? All of those are easy customizations that we've been talking through with a number of different agencies throughout the government.
Great. Other questions? Come on, folks, don't be shy. I'd love to hear a little bit more. Oh, here we go.
Yeah, I wanted to weigh in. I was the one that had the question about the ED
Thanks.
and data. And the question was more not, I know it's difficult to get the data, but we actually do collect a lot of ED data. We collect about 9 million encounters a year and aggregate.
Can you tell us which organization you're with? Sorry.
A company called Data to Intelligence, D2I.
Mm-hmm.
The reason I brought it up was that, you know, we've done a correlation that certain presenting complaints that tie to COVID diagnoses, which are often not known till weeks later, right, correlate, you know, perfectly to COVID diagnoses. So and I believe with COVID, one of the concerns is that the pattern can change very, very quickly. A single event in a particular county can alter the pattern very quickly. So really, I was more kind of asking the question about not to. I think the model is terrific, but would that data be considered very valuable to add to the model? That was the point of the question. Not to, you know, to criticize the current model, which is doing fabulously, but just to make it more of a leading indicator, you know, of where the disease is spreading versus a lagging indicator.
Yeah, no, that's a great point and a great question, and thank you for raising it. I think the short answer is absolutely, right? So right now, one of really the only way that we can optimize the model and check its validity is by looking at case counts, right? And so we'll take our projections from 3 weeks ago and look at how did we do in terms of projecting the cases to today, right? And we sort of optimize it against that. Because we don't have strong data on actual hospitalizations, right? And so to the extent that we could start to incorporate more of that data and use that as benchmarks against our projections and be able to fine tune some of those calibration aspects of the model, right? What the different percentages of cases that become infected mild, infected severe, infected critical, right, and end up using hospital resources, ICU resources, all of that would certainly benefit in terms of enhancing the fidelity of the model for sure.
Yeah. The other thing we discovered was that it's not just the hospitalizations, but in the data is that the average ESI level is becoming more severe, and patients are being discharged at higher ESI levels, which is, it's a lower number. The severity is actually a lower number, but which means that more people are being discharged that are ill, that are more sicker patients are being discharged. And if they're being discharged with a certain pattern of presenting complaint, that might be an indicator. Maybe they're being asked to quarantine, they're getting a test. Anyway, I just wanted to put it out there so it could be discussed with the group. That was the purpose.
Great. We've got some questions here about updating the model with 2020 census information and whether or not you're using ACS data for current population estimates from 2018.
Yeah, I'm nearly certain, Cameron, you can correct me if I'm wrong, but I'm nearly certain we use the ACS data, not the 2010 census data in terms of our population and all of the behavioral and social vulnerability statistics.
That's right. I don't believe the 2020 census has come out yet. If it has, please point me to it.
I think they're still doing it. Yeah.
Yeah, as soon as it's out, it's a pretty easy switch for us.
Got time for a couple other questions? Anyone? Okay. Ken, did you have a question?
Sure, I might as well put it out there. One thing that's sort of lurking in the mind of people as we get further in October into the fall is influenza. Now, that's probably very much mitigated by measures people are already taking by COVID, but is that playing at all or any data sources playing it all into your model?
Yeah, so the flu season coming around, obviously there is a lot of uncertainty with that. And we would like to potentially be able to, well, so the way that the model's set up is in a modular framework where it can actually be used to model any disease, right? As long as you have the proper data. So ideally we would have influenza and COVID separated and could, potentially model them separately, or if there is some overlap, we could try and figure out if there's some sort of overlap. But as for now, where we're standing, it's a little bit of an uncertain kind of wait and see moment.
Understandably.
Yeah.
It's a lot of uncertainty. It's not going to be like any other flu season, probably.
Right.
No, get your shot, everybody. Please. All right. Well, let's move on because there's another really cool tool here I want you to see. I've seen actually a sneak peek of this one as well. This is about kind of understanding what medical procedures projecting could be coming up or aren't being done right now, I guess is the way to think about it. Austin Haggerty, so you're going to walk us through this one. Can we hear Austin?
All right, can you all hear me?
Yep.
All right, thank you. So yeah, we'll be discussing a tool that we built for a couple agencies regarding the healthcare demand modeling. So we, shortly after the COVID lockdown took effect, we formed an internal work group to look at potential use cases. We work with a lot of federal agencies that oversee the health of a variety of different populations. So we were looking at ways that we could leverage our work with them to improve the response to COVID. And we started off where I think a lot of other companies did, looking at, predicting the spread of COVID, how things were going from that perspective. But we pivoted pretty quickly from there to, discussion on what the post-COVID world would look like. And if, what we could do to help with the response from a healthcare system perspective after, COVID lifts or in the later stages of COVID. So one of the things that we discussed was looking at the elective surgery backlog. So knowing that, especially when COVID first started, the lockdown, elective surgeries were put on hold and they've been greatly reduced since. So we wanted to see if there was something that we could do to estimate what that backlog was going to be, and to get a sense of how big of an issue that was going to be. There was a lot of literature at the time suggesting that the backlog was growing, that it was going to be unsustainable, and healthcare providers were going to struggle with that. So we wanted to take some of the data sets that we had access to and see if the problem did actually appear in the data, and then come up with tools that would help in that response. So we came up with some initial analysis looking at the data, and what we saw early on was pretty shocking, where elective procedures for things that were pretty routine that we would not expect the demand to dry up for were exploding. It was at times 25 times provider capacity for key things, hip surgeries and so forth. And I'll show some examples of that. And then we also started analyzing other potential, analysis or assessment that we could do to help understand what this meant beyond just hospital operations. And I'll talk to some of those use cases as well. So are we, what is the impact from long-term health outcome perspective? Are there, other impacts that we should be considering that we could help with if we took the data and did some analysis or built some tools? And even as recent as September of this year, there's a survey done where 40% of consumers said that they would wait until 2021 to have an elective surgery. So even though things have started to lift, and we're seeing that in the data, we're getting back to normal. We're still not there for many of the providers. There's a fair amount of the population that's holding on getting elective surgeries. All right. So what we did is we took historical data going back years to forecast what demand would have been like in the absence of COVID. And we found for a lot of the healthcare providers, the demand was pretty consistent and reliable. So we were comfortable with the estimates that we came up with and their efficacy in terms of predicting what that demand was. And we built an interactive prescriptive model to simulate the impact of demand based on a key set of assumptions. So and what I'll show you is a prototype that we built where we took the data, built a prescriptive model. We've since evolved that and iterated that for specific clients. But the goal was to provide a simulation tool where you can put some inputs in, shape it, and model what the potential outcome would be. And we built that as a web application using that data and a set of inputs. And for the facilities that we worked with, we were able to look at both inpatient, outpatient data, sliced it based on CPT, DRG, ICD codes. You could also break it down by facility. And then the key metrics or inputs would be the assumed data full return. So at the point that you feel you're ready to go back to full operations, be able to set that date, and then what is the capacity after you get to full return. In most cases, we're assuming, when a particular facility goes back to full operations, they're going to try to catch up on capacity. So they'll come back at 110, 120% to pick up that backlog. And then also we allowed for entering of a permanent attrition rate to the backlog. So we wouldn't just assume a straight linear growth of that, but we assume that some people will drop out, will attrit, they'll get care elsewhere, or maybe that particular type of procedure wouldn't be necessary because people are more sedentary or inside. They're not out playing softball, so maybe they're not going to have as many hip injuries. And then we also allowed for some cost modeling by providing an input to allow for designation of procedures to be sent to third parties. So for facilities that have community care or third-party relationships, they could model what it would look like to their backlog and then their cost if they were to send procedures out. Okay. And potential use cases were many, and we had a lot of internal ideation sessions and then conversations with customers looking at where they could leverage a tool like this. So first and foremost is supporting healthcare operations. It's looking at staffing, supply chain, procedure prioritization. So helping, model what things would look like and what the impact is on those different elements. And then predicting healthcare claims and costs. So if all elective procedures are shut down for a couple months or greatly reduced for a couple months, at some point there's going to be, assuming capacity exists to be able to action those, but there will be a bump and a return that's going to need to be accounted for, budgeted for. And as I mentioned earlier, several agencies we work with, they do use third-party healthcare providers. So understanding and managing, the workload with them, especially upon return. And then looking at impacts of delayed care. So from a population health perspective, what are we looking at for, cancer rates and the impact, and even things like dependency on painkillers. So with hip surgeries, if those are getting delayed while a patient's waiting to have that, there's a risk that they're likely being prescribed narcotics, and there's risk of dependency that could develop. So a lot of implications there, especially with vulnerable populations. And then other adverse impacts, are looking at limited healthcare options for at-risk populations. Are they more likely to be put in the backlog and not get access to care? And then also supporting military readiness. So understanding what the essential procedures are, making sure those get done so that our military is ready to respond. So a lot we could do once we had this data in there and we're able to come up with a simulation tool to start planning for different scenarios. And then challenges. So one of the challenges we faced right away was just the sheer number of procedures, especially looking at it from an ICD perspective. ICD-10 has 50,000 procedures. Winnowing that down, narrowing it down to what is essential, and then also identifying what's elective and what's non-elective. And then from a procedure perspective, they're often a very narrow view of the overall plan of care for an individual. So being able to bundle those and look at those in the form of like a CEOC or overall plan of care was an important challenge that we spent some time working through. And then the elective procedure utilization would not likely follow a consistent trend. So we expected, as we saw the actuals during COVID, that there would be some variation that would happen based on regional COVID infection rates, public confidence in the safety of procedures, and we certainly saw some shifts. Although, again, we're seeing an upward trend over time that's getting us closer to what we would expect, or we would have expected pre-COVID. And then the results, you know, when we took a look at the data, it was remarkable. We started plugging the data into the model, and that backlog, even with some pretty conservative assumptions, grew astronomically. And you know, that was shocking for our clients as well, and to the point where we, you know, provided spreadsheets that like laid out, here's all the data, here's our assumptions, here's our thoughts, and they went through and validated. So again, the model is not intended, or at least the early prototype I'll show you, which is synthetic data. It's intended to be used as a planning tool. We are working on products that are built more specifically for the use cases based on this initial prototype. All right, and then for the tool itself, so again, it's a full stack web application we built, and this is the prototype synthetic version. We do have versions that we built bespoke for customers. So I've gone in and selected DRG 470, which is a hip replacement or limb replacement. And if you take a look at the graph, we have the actuals in yellow. So you can see clear pre-COVID, and this is where COVID lockdown starts, a clear trend that drops off to almost nothing and gradually grows over time. And again, this reflects what we're seeing out there. It's not production data, but it is synthetic data that's been built along the same pattern. And then the red would be the expected amount if COVID hadn't come in, and we would expect the pattern that we have shown in red to be the demand. And then the purple is actually inpatient COVID admits, which we thought was kind of interesting to put in to compare, to show utilization, because you can drill down to a facility level as well. And that allows you to get a sense of what's happening in the community and also at that particular facility. And then finally, the big, you know, blue line up top here is the expected demand, or the calculated demand based on a set of features, which essentially it's taking and looking at the demand that would have, or the demand that's predicted in a non-COVID world, minus attrition, minus actuals, to calculate the demand. That builds on a weekly basis, and that's why it grows so quickly too. And then when we get to present day, then you can see that there's you know, a forecast based on recent actuals to cover up until the point where you set the assumed data full return. So here we've set January 24th, we're back to full operations. We're gonna come back at 30% higher, capacity. We're assuming a 10% attrition rate. And then the green line accounts for that 30% extra, shows you, hey, here's your new forecasted rate, which is above the baseline, and then you can see the backlog start to drop. And again, when we looked at this for a lot of the codes, put in some relatively conservative assumptions, we were looking at 40, 50 weeks to fully dig through the elective procedure backlog, which is pretty you know, pretty worrisome pattern or trend. So, and that's the tool. Like I said, this is an early prototype. We've built more mature production models for our customers. And at this point, I'll open it for questions.
Great, thank you. Here from Douglas, we have, for procedure backlogs, did you provide any clusterings for procedures based around specialties like eye procedures or GI procedures?
Yeah, so in the further iterations, like we'll break down ICD by higher level categories and CPTs by higher level categories. You can sit and slice and dice based on those different fields, and then it'll aggregate it up based on whatever you've set.
Great. Questions for Austin? You're going to have to unmute yourselves. Austin, can you talk about how this is being used right now and who's using it? You mentioned a couple of agencies. Can you talk a little bit more specifically about who's using it and how?
Yeah, we have a military health agency that is that we built a tool for, and they're using it for one of the goals is military readiness, but also to evaluate and understand the impact of COVID on their inpatient and outpatient procedures and to plan for that. And it's something that they've even suggested could evolve to be a tool to help them optimize their healthcare operations and what they send out to third-party providers. So I think it's given them a window they haven't had before into their historical procedures.
I'm assuming you need to have really high volume procedures for this tool to work.
Yeah, and we did see data sparsity, and that's kind of where I mentioned earlier. With a fair amount of the codes, they are pretty sparse, and that can be a challenge. But then rolling it up or aggregating or binning it can help you, still address those or understand the impact as part of a bigger view of the hospital operations needs.
So what kinds of trends, did this agency, I'm just curious, having this tool in practice right now, or have people been able to notice?
Well, I would say first and foremost, it was eye-opening when we did the backlog calculation to see what the expected number of elective procedures are that are waiting to materialize in the system. And then I think relating that to COVID, and then the slow return to normal, which is gradually occurring. If you look, like I said, this is synthetic data, but it's based on what we're seeing out there. There is a gradual return, but we're still, in October, not to full operations for many procedures.
Yeah. It'll be interesting to, it would be a great research study to kind of pull this from a few different spots. And does this translate well to the private sector? I know you said it was.
So we've had some initial discussions with, regarding potential for private sector, but our focus has been in particular on the federal space. And I think we'll see the impacts of what this model is showing for years to come, especially when we look at diagnostic procedures, for example, that are being delayed, and what that means for long-term health outcomes for individuals. For example, if they're not, if cancer isn't identified because they delayed an elective procedure, that could result in a more acute outcome, or a higher level of acuity and a worse outcome.
So this does include the diagnostic procedures as well?
Yes, yeah. So we have inpatient, which is where we started, because we assumed that would be the one most starkly impacted by COVID, and it certainly was. But also the outpatient ambulatory care, there was a noticeable drop as well.
So Ken's asking here on Austin's mention of lagged cohort, the effects of backlog in diagnostic procedures.
Yeah, and it sounds like he's confirming what I was saying, that essentially, we're going to see this, over the coming years, more of this manifest the results of these delays in elective procedures.
Yeah, really interesting stuff. I want to see this in a year with all the data. And so what's your prediction? Do you think this is going to even out, or what's your, certainly everybody at the very beginning of the pandemic was talking about this huge backlog, and so it seems like maybe that hasn't quite materialized.
Correct. We haven't seen a full return, and I think different individuals I think it's more about the individual's decision on whether they want to pursue a procedure or not, and so it'll be interesting to see how different populations are affected by that.
Yeah. Any last questions?
This is Ed Gamache in Health Current. The question I have is, did you look at any post-care impacts, rehab or nursing home placement, or is there any carryover to look at that, not only the hospital capacity to rebound, but also all these other care activities that have to be there? And then there's also obviously delays. It was kind of a compounding situation with physical therapy and things. So I'm just, this could go on forever, actually. It's just, it's very, very significant.
Yeah, no, that's a really good point. And we've stayed within the bounds of, the procedures that I mentioned, but the post-care, I think, would be a fascinating area to look at, and the impacts on that, and how that system is either being stressed, as patients return.
I think the other thing, long term, I could see cancellations for individuals, because a lot of individuals wait for the last point in time, particularly knees, not maybe as much hips, but knees. And they could get to a point where they say, you know what, I can't see it. I'm just got a year older. I'm not gonna do it. So I think that's a potential. And then also some of the results, because if it's delayed long enough and you have a delayed procedure, your potential for rehab back to what you would consider what you're looking for may not be as great. So I think, the potential impact of delays a lot more than just, you've captured it well, but it's more than that. It's also the long-term impact on the individual themselves. So.
Yeah, agreed. And it's certainly something that, we've talked with population health experts on, and others, to start to understand what the potential implications are, and whether there's things that we can do to help. And we had started initially by looking at scheduling data, by the way, to see, okay, we knew that people were being put in a backlog for scheduling, and it was not representative of what we would have expected. The numbers were far smaller. So that's why we went to the historical data to try to predict what the backlog would be.
Yeah, and the only other thing, I'll leave this go. You just got me going. I'm sorry, but
no, it's good.
The last point would be: there's no way to know the impact of people putting off their procedure now, because of the procedure you have to go through with COVID, and say, I really don't want to do that. I don't want to get tested. I don't want to go. And then the other impact is because family members can't. It's opened up, but for a while there are family members. Even if you could get the procedure, your family member couldn't be there, and that's something that would really have an impact, either delaying it or certainly could potentially impact the care itself.
Yeah, or the recovery effort. Yeah, that's great. Yeah, thank you.
Really good point. Other questions? It would be interesting to see, Austin, how this compares if you use this with the other model, if you could show an increase or a decrease based on the risk area. If open.
And that's where we were looking, because we pulled up some hot areas like Houston, I'm down here in Texas, like Houston popped up, and what was elective. And we saw some shift and some change, but it wasn't a dramatic effect like, COVID is going up, people are no longer doing elective surgeries. So I think it's different populations too. The folks that are out and about, even, in spite of rising COVID rates, are also the ones that are getting the elective surgeries, right? So
yeah.
You can hypothesize some of those patterns. So we didn't see as much of a depression in the elective surgery rates, when the COVID rates are rising in a given locality.
Yeah, it'd be interesting to see.
Yep.
Okay, last chance for questions. Going once, going twice. Okay, great. Thank you so much, Austin. This is fantastic stuff. Again, I think, in a year, we want to come back and see all this data pulled together. So, okay, next we are going to Ryan Ashcroft with Contagion. Got a really cool tool here. Do we have Ryan? Ryan,
yeah.
Can I hear you? Oh, great. There you are.
All right. So our approach is a little bit different than what you've seen so far, right? So what we're really looking at is how do we take the different data that's out there and help make it more actionable for folks. So a lot of our background actually comes from supporting folks that have facilities and looking at how do I handle those facilities. And compared to the broader economy, perhaps some of the decisions of do I open this building or close this building might be a little bit smaller, certainly, right? And definitely more tactical. But there are some big decisions for folks to make. So let's see here. Actually, should I be taking control? Okay, thank you. Next slide. I appreciate it. So for us, what we're really looking at is how do we help organizations get back to normal? And as we do that, what we want to do is say, hey, what are the factors, right? As we go back and start to look at reoccupancy and getting people back into offices and making it worthwhile, how do we do that in a way that's going to work? And of that, we really see in talking to a number of folks, a bunch of different challenges. Number one, and probably the biggest impediment right now, is making sure employees feel comfortable coming into the office. And we recently took a poll of our own staff and actually found that 10% were interested in coming back to the office anytime soon. Some people are those 4%, those 40-person company, those 4 people really wanted to come back in. Most people have no interest in even considering it before January. So there's, how do you make people feel safe? So it's one thing for it to potentially be safe at some point, but then there's how do we help people feel safe when they come back in? And how do you make them feel safe that the next thing is going to be there, whether that's an additional wave of COVID, or whether that's some other, difficult flu season, or some other illness that comes through that we all need to deal with. So we want to really look at that and make sure that's working for folks. And then finding something that's sustainable, that works going forward, right? Because, similar to how we've had giant cyber attacks within the industry over the last decade, and it used to be that people didn't have plans for dealing with that. One of the things that we think, and what we've seen when we've been talking to folks, is that there needs to be a plan of attack for how we can move forward so that folks can feel safe in coming back and in pushing through. So it's not really wanting to let me move slides here. So if you could move to the next slide. We can go one more, please. Thank you. All right. So how do you get to a new normal? And I want to really maybe highlight one of our clients who we've talked to about this. When COVID started to hit and they had symptoms, people who had symptoms within their office, their bill for doing a deep clean of their headquarters was $3 million every time it occurred. So for them, this is a really big deal. They have no way to pinpoint where is it. Their headquarters is actually multiple buildings. And so when they get one potential reported case, what they would do is respond by closing down the building, and then they would do a deep cleaning for the whole thing. So you can quickly see how 2, 3, 4 potential reports suddenly becomes a pretty big financial deal to them, and it starts to really impact where else they can spend money and how they can maximize the value for their particular mission. So the other thing we've heard from a lot of folks is that the way it's handled today is really largely related to just going around and having an unofficial spreadsheet, right, where people track data, or it's somebody's writing it down in a notebook on their desk because they don't have a good way to track who's been impacted. And then how do we decide, do we need to do contact tracing? Do we need to shut down their building? Do we need to send some people home to quarantine? There's a lot of questions that are happening. And frankly, even within individual organizations, what we hear is a lot of variation, right? SCIFs are a super interesting aspect of this, right? Within the government, where different SCIFs often are run by different people who set their own policies. I can even just tell you from a personal perspective, I'm involved with 3 youth sports teams with my kids. All 3 have different rules that are somewhat inconsistent and somewhat overlap, and people consistently confuse them and how they work. So there's so much variability here that it really starts to become hard to take some of the great analytic information that we've seen in prior demos and that exists, broadly within the community. And how do you make that so that it really is easy for people to take that and make recommendations that are consistent, that are appropriate, and that are going to work? So we need to help folks do that. I think the other aspect of this that is really interesting as we've talked to folks is that guidance changes frequently enough that it's difficult for everybody to stay on top of it. And I know, personally, one of the things I always try to do is not take medical advice from the news, right? I want to get that from my doctor, or I want to get it straight from the CDC or some source that I consider is reputable that doesn't have interpretation. But we're all being bombarded with information from different sources with different perspectives, and frankly, you can find studies that show different results for similar aspects of problems. It becomes really hard to decide organizationally, what are we going to do about COVID and how are we going to handle that, or whatever disease comes next. So what we wanted to do is really help by taking the information helping people codify the rules that are out there and then applying them to the data that's available to say, hey, what are thresholds that we should apply within our building? Is there a point where we should have a mandatory mask policy because there's a new respiratory disease going around? Or should we shut down this building or this floor or this skiff? And starting to look at different options, or going into a essential only work arrangement, and trying to really help out with how do you do this in a way that is proactive and not reactive to where we're shutting down the entire building or we're having to take big, bold steps, which sometimes may still be the most appropriate thing. But if we can get to a spot where we can, as we learn, we can be more targeted, we can save folks money and keep people back into a more normal space, and then also just help people feel more safe going back into the office. So we took as just an example the Navy, and I'm going to just kind of quickly go through this because there's a lot of interesting scenarios with the Navy, right? The Navy is not a client for this, to be clear. Just in a use case that we really looked at applying this to is that when you look at the Navy, they have ships, they have buildings that are on land, right, and all around the world. And so as Navy ships come in and they leave, there's all kinds of potential disease vectors that occur as you do that. There's also aspects of when can I shut this down, and when can I see, hey, folks in the engine room are all reporting that they're ill. What are we going to do about that? Or do we need to start to go to shifts? Do we want to go ahead and skip the scheduled port stop because there's a potential issue? Do we want to screen for issues like COVID or the flu? But maybe we also want to look at Saberni-related side effects, right? Things like we saw in Iraq this year, where people had concussion problems, days and weeks after the attack on the base in Iraq. So there's all kinds of interesting scenarios to potentially work from and work through there. And what we're doing is not so much looking at here's a ready-made solution that considers all of those, but here's a framework that helps you take in the data that's available and then apply your rules that you would like to leverage for your organization and help make those consistent and actionable so that you can make employees feel safe. And with that, I'm gonna actually transition over to the demo here. And so for that, let's see, apologize.
1A, I think you need to give him control. It looks like it's on your screen.
What I can do in the meantime is I can kind of talk you through what's going on real fast. One of the things that we do is there's tons of options out there which will let you collect data. I personally fill out waivers for my kids for their sports constantly to say, hey, do you have these symptoms on a daily basis? And we certainly do support that. But what we also do is we let you come in and say, hey, here's some information about me as a member of this organization, whether I'm sitting at this in this building or I'm remote or whatever the case may be. And I can decide how much information I'd like to provide. I can also say, do I have a serious medical condition? A lot of folks aren't really interested in sharing the details, and we don't really want to be in the business of collecting and storing detailed medical information. So what we do is we just ask you, are you directly or indirectly at increased risk? So perhaps I live with somebody that has a number of comorbidities and is older, and so they might be at a very high risk for COVID. And so we use a sort of a transitive way of looking at that to say whether you should come into the office or go to baseball practice or whatever the case may be, could be then directly correlated to whether or not you are directly or indirectly at risk. We optionally allow people to provide that. We optionally allow people to provide their age, since that's often another substantial indicator. And then using that information, we take in what the different reports are for your symptoms. So I'll use an example of a floor that has a few different divisions. If in the marketing division, we have a couple of people that are reporting that they have a fever and perhaps coughing, we may want to shut down the marketing division because we know that those are high risk symptoms for COVID. And one of the things that we do is we collect up all that kind of information as you report it in, and then we show it to you in a really simple easy to use graphic. So you can come into our dashboard, you can see how many of your staff have reported whether they have symptoms, symptoms that we would recommend they work from home. I've got a fever, hey, let's not come into the office. If you've got a fever, why don't you just go ahead and stay at home? And again, you can codify that knowledge into the tool. So when they report their symptoms, it just tells you your combination of symptoms is something we really would rather you not come into the office. Please work from home today. Or, you know, you've got a headache. That's fine. Come on into the office. And so it helps them make that decision. So they may have safe symptoms like a headache or, you know, loss of sense of smell or taste. We're probably going to go ahead and say you should just be working from home. And that's all configurable for different sets of symptoms. So you can have those for flu, for COVID, for whatever you'd like, and load them in, and they can all be screened off of the data that's being reported on a daily basis. We'll show you trends of what staff is restricted and what staff isn't, which you can kind of see here in the middle of the screen. And then we can also show you what percentage of staff are reporting which specific symptoms where we have the data. And you can compare that to kind of have this sort of like fingerprint comparison of, you know, how do the actuals that are being reported compare to the flu? And in the visualization snapshot we have here on the screen, you can kind of see that the flu and COVID actually look a lot different when you start to look at symptoms and percentages of patients that report those symptoms. And so, so when we sat down and looked at that, we could say, hey, the actuals, which are the red dots, they don't look anything like the flu. There's some overlap with COVID, particularly, you know, on the more commonly noted COVID symptoms. So maybe we need to be a little bit more careful here in the building. We want to make the data a little bit easier for somebody who has to make the decision to open the floor or close the building or whatever the case may be. What we really want to do is just help make that a lot easier for them. You'll also note that there's some lines in the restricted staff trends chart here. And what we can do there is also set some thresholds. So you know that as people reporting symptoms exceed certain thresholds, it will tell you, hey, this is too high. We need you to go ahead and report, or we want you to close this floor, or we want you to require masks today, or we're going to do mandatory temperature checks. It's 100% configurable based on your organization and what you'd like. And then we just really simply roll it up. So you can roll it up based on your building, your region, the state. You can get within a building and start to look at where are my floors or where are the skiffs that are within floors. And you can really quickly just click in and get the same view, but at that very detailed level for the space you're trying to make a decision for, I should say. Or you can go back up the roll up and you can move it into, I'm looking at all of my facilities that are within Virginia or Fairfax County and so on, so that you can make really tailored decisions for what you need to accomplish. So that's kind of the quick overview of what we do. I apologize that the demo didn't work out exactly as we'd like, but that's kind of the gist. And I'd always, of course, be happy to run somebody through a live demo at another time. So again, a little bit of a different take. It's more tactical of how do we apply all the great data. And I think one of the use cases that we've certainly looked at is, you know, how do you take the data perhaps from the SRS tool that we were initially briefed and maybe put that in so that instead of people reporting symptoms, perhaps we could look at, here are the symptoms for what's going on, or here's what's going on in Fairfax County. And so let's make decisions based on that. Or if we know where people are from in our particular building, we can blend perhaps that data between Fairfax County, Loudoun County, and perhaps even counties in Maryland where it's a complicated area like the DC metro area, to get something that's perhaps a little bit more actionable for your specific building. We know certainly that that's a case. Fairfax County School District closed because they weren't concerned about Fairfax County's numbers, but they were concerned about some of the numbers that were within surrounding areas where they have staff that come in, and they wanted to be really careful. So by taking a lot of the data and trying to help make it more actionable, we hope to be able to help organizations more smoothly apply their standards and hopefully make it easier to make more targeted decisions where possible.
Okay, great. Thank you, Ryan. Questions for Ryan? I love the example, Ryan, that you mentioned with Fairfax County. I'm in Maryland, not Fairfax, but I love the example anyway. Can you give us a couple of other examples where this could be used?
Yeah, certainly, right? So like I mentioned, we've got a couple of clients that have buildings that are large campuses, right? And right now they make a shutdown decision that's based on their entire campus. And that's a real challenge. I think one of the most common things, though, that we've really heard are SCIFs are a really big problem, right? SCIFs are, people don't move between areas within their SCIFs. So you go to this place, you work in it all day. And so making sure that those have applicable rules, and they also are specialized. Some of them require national security or have national security impacts. So they're not going to close at the same rate, perhaps, that a different location might want to close at. They're going to have to take different measures in order to make that work. And so helping them to like get into some of the data and slice through that is something that we've heard a lot of interest in. So, you know, schools, I think anywhere where you have a lot of folks that are coming in and you have a lot of different segmented rooms, ships, schools, factories are all places that that seem like they would be pretty applicable. When we first started doing this, there was a lot of pushback on the idea of people submitting daily symptom reports, and we love to get out of daily symptom reports. All the doctors that we have spoken to about this all say that's great. If you can get me temperature data, if you can get pulse data or resting pulse rate data, if you can get any kind of other data of what's going on in the counties, anything that is not controlled by a patient who may not give you a completely honest answer all the time is going to really help make this more accurate. So I think we'd love to, of course, blend that in. But now what I'm finding is folks are becoming pretty accustomed to submitting daily symptom reports, and it's sort of a fact of life, at least in the short run.
The only thing with the symptom reports is if we know that about a third are asymptomatic, you know.
That's why the other data sources are so important, and having something like the safe return simulator kind of data would be super impactful. Yeah,
really cool. All right, well, thank you so much, Ryan. Appreciate it. All right, next we're going to go to Jesse Tetrio, so with solutions architect with NVIDIA. So, Jesse, do you have a demo or just slides?
Just slides.
Just slides. Okay. All right. So you have control. Can you do that, or 1A or Sarah? Who's doing the slides?
It says I'm controlling.
Okay.
Oh, just exited here.
All right. You got it.
Make sure I can click here. Looks like I'm getting spinning windows here.
Okay.
Here we go. Okay, great. I got control.
Great.
So my name is Jesse Tetrio. I'm a solutions architect at NVIDIA. And today I want to kind of go over the litany of solutions that NVIDIA has been helping partner with in order to fight COVID. You know, like Ryan's talk, it might be a little bit different. I think a lot of times what we're focused on is really enabling developers to be able to use our you know, accelerators, our GPUs, to be able to solve different problems. Certainly, epidemiological modeling is one of those. You know, raw visualization in some cases, you know, is where we can aid. There's a lot of work within drug discovery, you know, whether it's from a mitigation perspective and some sort of drug that you can take to mitigate symptoms, or a vaccine. A lot of those workflows share these same kind of genomics workload, you know, big data analysis things that can be accelerated on a GPU. And then also, which is what I'll be focusing on a little bit more today, some of the radiology and computer vision solutions that we can accelerate in order to not just help the end radiologist, but to create higher fidelity tools and data to be able to even feed some of the other models that we've discussed today. So I want to pause right here to talk a little bit, just a couple words about the genomics and the drug discovery piece, as I won't be focusing it on the rest of my talk. But you know, there is, we have a piece of software called NVIDIA Parabricks, and this helps with secondary and tertiary analysis of genomes. And basically at a high level, you know, finding a drug and doing the drug discovery process is an enormously complex and multi-stage endeavor. You know, first you have to be able to sequence the genome itself through base calling techniques. You know, it's not just as simple as reading the letters off of the genome. There's some uncertainty there that the machine learning and analytics can help with to be able to kind of denoise it a little bit. Once you have that first primary analysis, the secondary analysis of assembling the actual genome from the different pieces and using that to predict the structure of proteins directly from an assembled genome is something that is very difficult, but we're making traction on. You take that prediction of what the protein structure should be, right, and you kind of marry that with some cryo-electron microscopy, actually imaging what you can see and trying to find the structure that way. You have these kind of two different pieces of information that meet in the middle of, you know, thinking what the protein should look like and marrying that with a possibly noisy or not 100% fidelity image from the electron microscope and being able to find the structure of spike proteins. And I won't belabor it, but after that, you know, there's a lot of different, you know, docking and protein ligand interactions and molecular dynamic simulations that need to be done. And every stage of this, you know, I'll call it 6 or 7 really high level phases in doing a drug discovery can be accelerated on GPUs. And we have worked quite heavily with the Parabricks team to accelerate those solutions. So I will try to advance here. A little bit of the slides transitioning okay on you guys' end? It's a little choppy for me, but
yeah, detection and prediction says.
Got it. Right. So the first piece, the piece that I've worked on personally closely is detection and prediction using NVIDIA Clara. And Clara is basically our toolkit for medical image analysis, or you know, it focuses a lot on radiology, but certainly has some kind of pre-baked solutions for pathology, a couple genome pipelines, things like that. So I want to focus on this first. There's 2 specific models that we've developed that I want to present today. One of them is the lung CT COVID-19 classification pipeline with NVIDIA Clara. So before I get into the details of this and the next slide I'll present, I'll preface it by saying, you know, all of these components in this end-to-end pipeline are available, you know, for free as pre-trained neural networks that NVIDIA has worked with. In this case, with a CT COVID classification pipeline, we got a lot of partnership with the National Institutes of Health Clinical Center. So we used a lot of their cohorts to be able to train our models. But these are all tools that you can go, and while I don't have a demo interactive at the moment, you know, this is all free software you can download and repurpose or add on to. So the COVID classification pipeline is actually 2 separate neural networks, as well as some kind of peripheral regular software components. So having a CT of the lung image in DICOM format is the first component, and once that DICOM image is read in, the first step or the first component of this is the DICOM reader. This is packaged as a Docker container, a standalone component, so they can be reused. And really the job of this is to extract the DICOM series, do a lot of the traditional medical image processing that you would have to do the pre-processing, the normalization, extract the header information and things like that, and prepare the raw pixel data to be able to be ingested by a neural network properly. Once the DICOM reader is finished ingesting the data, the first neural network receives the data here in the lung segmentation model. So we actually found it empirically a little bit better to be able to segment the lungs in a CT image before passing it to a classifier. The classifier's eventual job is just basically to give us a confidence prediction of you know, how likely somebody has COVID. But when we went directly from DICOM to classification, we found that it wasn't as reliable as segmenting out the lungs. So we kind of took a step back and trained a specific neural network just to segment out the lung tissue within the CT image. Once that is done, then the classification model, which is a second neural network, takes the output of that first AI model and predicts a confidence score. So this is, you know, 3D image data. We segment out the lungs and organs of interest, and then we pass that to a classifier. And as an example, you know, it'll really just give you an output of 98.4% confidence this person does or does not have COVID-19. And then there's some additional, post-processing type operators to render it, the visualization, so a radiologist can actually look through it and visualize it. This is not only a model that is available right now and is free, on our website, but we've actually integrated this into the Clinical Center NIH PACS system, and they are using it on retrospective analyses right now. And so, a radiologist who is not even trained in data science per se can go through their typical clinical workflow and, submit these DICOM series and these different studies directly to, the NVIDIA GPU server that is running these models 24/7. And within about 60 seconds, the output, including the mask of the lungs and the confidence score, is stored back in the original PACS system. So, not only is it a great tool, but it really has gained some clinical traction. The last thing I'll mention about it is there's a third model that we are developing that will eventually grow this pipeline that actually looks into the lung CT image and does what's called a ground glass quantification. And so the ground glass segmentation or quantification refers to the actual visual presence of the pieces of the lung that have the COVID infection. And so eventually we will have both a segmentation mask, a confidence score, and kind of a heat map, if you will, of the lung images of where radiologists maybe could look a little bit more deeply or kind of point out the infected areas. The second model that I want to present that is just came out yesterday. It's been a couple month long collaboration. This is the exam initiative, the EMR chest X-ray AI model, also trained within the NVIDIA Clara framework. This is a result of 20 different institutions from 12 different countries internationally pooling together their chest X-ray data and EMR data or EHR data, such as oxygen levels, metabolic panels that may be performed, kind of your typical, blood tests of a patient that would come in with suspected COVID. We pair both the image and the EHR data into a model that can predict what kind of oxygen level a patient will need within the next 24 and in the next 72 hours. This is extremely, extremely powerful. And, we're pretty proud to say that it's about 94% area under curve in its accuracy on a training set of somewhere on the order of about 8,000 to 10,000 data points. So this is a large data set with a very high accuracy, and we're really hoping that, like I said, it was just released yesterday, but we're really hoping this can be adopted to better forecast where to route patients within the clinic, who needs to go to the ICU, who needs a ventilator. Obviously that is one of the things, especially early in this whole COVID pandemic that everybody was worried about. And so to our knowledge, this is really the largest, multinational collaboration like this. The technique that we use to train this model is called federated learning. And all 20 of these institutions, including Taiwan, Japan, Italy, UK, several institutions in the US, sharing data is always a very difficult and it's, if not impossible at times, delaying activity that can really have to go through all the jumping the hoops of sharing the data and things. And this can really take away from, the time to solution. So federated learning basically, can take advantage of all this data that is distributed within these 20 different institutions and leverage it all without actually moving it anywhere. And so, at a high level, what you do is set up a AWS server or Microsoft Azure or whatever your cloud of choice is as a centralized server, all right? And at the start of training, everybody at these 20 institutions gets an identical neural network with the same architecture, the same layers. In this case, it would be a ResNet with 34 layers in it. And everybody does one iteration of training on their data locally. After that iteration is done, everybody sends the model, the new version of the model, to the centralized server. The centralized server now has 20 different copies with slightly different neural network weights, all in one centralized location. And it can do something like just kind of average the weights together, or, there are more sophisticated techniques for kind of, marrying all that data together. But in any case, it aggregates all this data, it averages the weights between the 20 models, and then it sends back that same copy to everybody else back in the 20 institutions, and they do another iteration of training. And so if you can see, the data never leaves the premises, but the neural network that is eventually trained at the end gets the advantage of seeing all of this data. Not only is this powerful because more data is typically better in almost any case, but in the multinational setting, the international setting that this was trained, there are a lot of different patient populations in which we go to the Department of Veterans Affairs in San Diego, which was one of our clients, for example, and train a model to 98% accuracy, and we ship that model over to Japan. The patient population may be so different. It really gets back to this fact of the model isn't going to be able to generalize as well. And so we're pretty pleased that we were able to take advantage of all these different patient cohorts, different imaging systems at all of these different institutions, and train a model with really high efficacy of being able to predict ventilation. Mentioning how to build on this, or where you could go from this. If you have EHR data in any kind of imaging modality, this could be adapted to predict any other type of value that you're interested in, perhaps, in a different non-COVID related scenario, just, the amount of blood transfusion that would be needed after monitoring a patient for 24 hours in the ICU, and you collect all these EHR data, and, take a chest x-ray or CT or MRI, it doesn't matter. This is really a framework where many times just the image modality is considered, or sometimes only the EHR data is considered. And, this is a framework where you can kind of combine those two to get these deep insights. And it's, hot off the press, and we're very excited about it. The second set of solutions I want to go through real quickly that may be a little bit more applicable, as I was kind of saying at the beginning here, of creating better data to feed the tools that some of the other presenters have gathered. I mean, it's been mentioned several times that getting these fine-grained details is sometimes a challenge, and that's going to remain the case. But however we can enable people to collect higher fidelity and better data to feed these predictive models, is going to be advantageous. So this is what I want to present here is something we call Clara Guardian. It is another kind of umbrella of Clara. I was talking earlier about Clara Train and Clara Deploy for respectively training and deploying neural networks. Clara Guardian is kind of this other subset of functionalities for enabling smart hospitals. And funny enough, we really started on this endeavor before COVID, where we just pretty much thought, smart hospitals, how can we make hospitals more intelligent? If we put a camera in every patient room, what kind of neural networks or analytics would we want running on them in the ICU during surgery? How, patient monitoring, fall prevention, these are all a bundle of use cases that's focused on patient care. And we started on that endeavor, really last November or December. This is one of our newest libraries, and it's still quite under development. But, with COVID, it presents quite a unique use case to collect some additional information. Some of the different functionalities, and again, these are typically in the form of either pre-trained neural networks that we have collaborated with our clients on, or in some cases when, for privacy or whatever kind of reasons, we can't share the model directly. As is the case with the face mask detection model, we provide a recipe of scripts that has the neural network architecture already set up. What you really need to do as a developer is just point it to your data set and tune a couple knobs for the hyperparameters to train on your data. But, it's kind of this litany of solutions within Clara Guardian, whether it's gesture modeling, pose estimation, a relatively new one, the heart rate model, and then, even just detecting and counting people in RGB images, or infrared images, perhaps, is something that can be interesting, both for patient monitoring at a smart hospital and in COVID. Another use case that really pops in my head that isn't even pictured here, but, I've heard some of our researchers internally discuss is detecting contact on different surfaces. You could take a pose estimation model as well as a depth sensor to try to figure out how many people are touching these kinds of surfaces. You could use that to enhance your contract tracing and then feed it to the COVID safe return simulator. Maybe one county, the largest hospital, the way that it's architected literally physically may have more contact between patients, things like that. So again, these are all kind of pre-trained models or solutions like a recipe, if you will, for getting started in all of these different areas. And one more that I will specifically highlight here, if my slides will change. I apologize. There, oh, I must have done it 4 times. Apologies there, Sam. So the last thing I want to, within this kind of umbrella of different solutions is the AI-based face mask detection model. And so this is if you find this blog that I have in the middle here, there's a recipe ready to go with the neural network architecture. We have the data sets that we used, with one of our clients to train these models. There's some Kaggle, open source data sets. The MAFA, the masked faces data set is a relatively new one. And even existing data sets, the celebrity data set, this has been used in many different experiments. And, honestly, we could take advantage of a lot of different faces without masks because those already exist. And what we're really trying to detect is it a mask or not? So we need just as much data of masked images as not masked images. So the data set, the neural network architecture, the library, the container, and the software stack to be able to get started with this and adapt it to your own data, is all available through NVIDIA. So I think that's what I had to present. So I'd be happy to take any questions at this time.
Great. You do have a question here. First of all, just really impressive model, and I love what you guys released yesterday. Is that being used right now in hospitals? Is that available with the AI with the lung scans? And
so the first that I presented, the lung segmentation and regular COVID classifier that gives you a confidence score, both of those neural networks are bundled together in a pipeline that is available right now on NVIDIA's website on NGC. The one that predicts the exam model that predicts the oxygen level in the next 24 and 48 hours, or 72, excuse me, that was just finished up, as I mentioned. And so I think the participating institutions will have access to those models in about a week or 2, and we plan to make it publicly available sometime within 5 or 6 weeks, if I'm being realistic about it. But at that point, the pre-trained weights for that neural network will be available to the general public.
So when you say the institutions, is that something NIH was involved in, or what research groups were involved in that?
Yes, so within the U.S., Mass General Brigham, as they call themselves now, was one of the leading institutions that helps. They're a strong partner of ours. National Institutes of Health Clinical Center, I help them directly, prepare their data and get involved in this. So that was one of the institutions. The Department of Veterans Affairs in San Diego was one of the participants. I believe Ohio State. There was a couple more in the U.S., and then there were Italy, there was one hospital in Italy that was able to share some data and participate, which was, really beneficial to us. As everybody's probably aware, Italy had quite a strong spike there at the beginning of the wave. And so their imaging data from even 3 or 4 months ago was quite insightful. And, Japan and Taiwan, there's an exhaustive list, but there were several within the United States.
Great. And I know we're short on time, but I'd love for you to answer this question about the federated learning process. And can you talk a little bit about what's happening at the centralized server?
Sure. So like I said, only the model weights are transmitted back and forth at the end of every epoch or iteration of training. And really what it is, to simplify, is really just averaging the weights together of the 20 different models or however many participating institutions there are. Because everybody has the same neural network architecture, it makes it a little easier to average the weights. But it's an active area of research, how to combine these different distributed models at each iteration. You could have a weighted average, for example, which we did experiment with a little bit. And there are many other kind of, researchy techniques that you could use to either, remove outliers or, weight the average by how many images there are at one institution. Obviously, if one institution has 20 images and the other one has 3,000, you're going to want to weight that one more. So there are a lot of different ways to combine it. But, at a high level, it's really just transmitting the model, averaging all the weights together so everybody's on the same page, everybody kind of syncs up, and then you redistribute the model to these distributed institutions so they can do another iteration on their data.
Fantastic. Any other last questions for Jesse? You want to unmute yourself? Give me a second. Okay, Jesse, thank you so much. I mean, I'm really interested and looking forward to seeing what happens with this data. I mean, really incredible work. Thank you so much for this.
Thank you. Thanks for having me.
Fantastic. All right. Now we're going to go on to Dr. Scarpino with Northeastern University. Forecasting, more forecasting and mobility. This is pretty cool, actually. This is some cool stuff. So, Dr. Scarpino, do you have, are you doing your slides here?
I can do either one. I would like to show just very briefly one of the dashboards that we put together, which I'll have to do on my end. So I don't know if it's easy.
So 1A, if you could stop sharing, or Sarah, and give him access. There you go. You should be able to share now.
All right, great. And let me see here.
It's open, hopefully.
Okay, great. Is everybody able to see my screen?
Yep.
Great. So just very briefly, I can introduce myself. I'm Sam Scarpino. I'm an assistant professor in the Network Science Institute at Northeastern University. I'm also external faculty at the Santa Fe Institute. At Northeastern, I direct a research lab called the Emergent Epidemics Lab, where we focus on constructing mathematical and computer simulation models of infectious disease outbreaks, and then translating the results of those outbreaks into improved public health and clinical decision making. We've worked as a part of every major infectious disease outbreak and pandemic since the 2009 H1N1 pandemic, from Zika and resurgence of yellow fever to Ebola in West Africa, and certainly now COVID-19. And our approach is to leverage multiple data modalities to inform both the mathematical and computer simulation models that we construct, but also to develop tools for enhanced situational awareness, event detection, and early warning systems that we hope translate into improved decision support, in particular around public health policy. And as a part of the COVID-19 effort, we've been co-leading a number of international teams that have been working to make derivative information from high-resolution telemetry and mobility data available to the public and to decision makers, and also available to power forecasting models to digitize public health policy data nationally and internationally around COVID-19. And to curate an open data set of individual level COVID cases that now has around 3 million cases in an open access database from 160 countries that we're projecting will have about 10 million, or a third of all reported cases by December. And so I want to, again, thank the organizers for inviting me to briefly tell you a bit about what we've been working on, and show you at least one of our dashboards, and then I will also say a little bit more about some of the forecasting models that we've been doing. And so first, before I jump into the slides, I'll stop sharing here and share my computer screen for the dashboard. Great, so primarily In collaboration with Cubic and through Northeastern University, Professor Alessandro Vespagnani, we have developed a high-resolution dashboard of mobility changes throughout the United States that we can track here from early February, basically through a couple of weeks ago. So we get the data in on about a week lag. And we have access to data down to the county level, but on the dashboard, down to the census block level, but on the dashboard, we provide information at the state or combined statistical area level. And what we're able to track here are 3 different measures related to social mobility and interaction. This first measure is the number of unique, or the percent of unique social contacts outside of the household that an individual has during the course of their day. So we're able to identify an individual's household, exclude the contacts that they have within the household, and then track the contacts that they have throughout the household. And we can compare, say, the Boston area to what we're seeing nationally and in Miami. And a fairly similar pattern emerges, that you have clusters of states, cities, and the entire United States that differ in the timing in which you see changes in mobility pattern. And as was alluded to earlier, quite a bit of these changes in mobility pattern are due to individuals making kind of endogenous decisions in their community, and it seems to have less to do with specific guidance or recommendations or even orders that may be coming down at the state level. For example, in Boston here, actually, if I pull up Massachusetts. So here you can see Massachusetts coming online in yellow with quite a large and early drop in the number of social contacts, although we never actually had a shelter-in-place order from the governor. And you can see that we actually had persistently low mobility, low social contacts moving into the summer. And then, right about the time we start to see an increase in our cases is when the social contacts go up. We also have more information around this. This is mobility outside of the household within the census tract, but not for work. So we can identify statistically, at least, an individual's workplace and monitor their mobility patterns, excluding work. And then we can also monitor individual patterns associated with transit for work that we call commuting. And so these data are used both to provide a measure of situational awareness, but also to power mathematical and computer simulation models that try to disentangle the effects of various policy interventions on COVID-19, on human behavioral response to COVID and to policy interventions, and then also to ultimately try and forecast some of some changing demand at the hospital level, in increasing or decreasing cases, many of the things we've heard about today. So I'll jump back into the slides here. And I think in the interest of time, I'll just go through this piece very, very quickly. And I wanted to mostly highlight this as a call to action around specific kinds of data sets. So one of the particularly challenging things about COVID-19 is that it is a disease that's not particularly well characterized by the average number of secondary infections, crudely referred to as the R0 or the R0. And a great example of this is that a 1918 flu and 2013-16 Ebola in West Africa had approximately the same average number of secondary infections, obviously very different stories in terms of the global effect of the pandemic. And if we use different forecasting measures for the total percentage of the population that's at risk for COVID infection, just using the average number of secondary infections, this is what we would get in red here, and the dot is the best estimate. The range represents not uncertainty, but different point estimates of the R0, the average number of secondary infections, ranging from 50% up to close to 100%, with the best estimate being around 80. And we see this in some settings, naval vessels, fishing boats, places where you do really have tightly mixed communities of individuals. However, if you include the heterogeneity in transmission, the effect of super spreading events, and the importance then of stochasticity on the maintenance of these transmission chains in populations, you get a much lower estimate of the proportion infected, somewhere around 20%. And this, of course, also complicates individuals' conversations around herd immunity or around effective strategies for vaccine deployment, because the reality is that this disease is kind of moving back and forth between these two regimes, a regime that's highly dependent on super spreading and dominated by stochasticity, and a regime that is largely deterministic and kind of marches along like influenza. And so we need to account for these with data and then our models, especially as we move into the spring and start to deploy vaccines, hopefully adaptively with other non-pharmaceutical interventions in the United States. The other, and this is the piece that I mainly wanted to tell you about in addition to the mobility piece, we've been working with Google.org and a consortium of 7 research institutes, in particular Northeastern University in Boston, Georgetown University, Johns Hopkins University, Oxford University, and Boston Children's Hospital and Harvard Medical School, to both identify, capture, deduplicate, clean, and merge data on individual level anonymized cases of COVID-19. And this is covered back in June in the New York Times. At the time, we were an informal network. We've now formalized a bit, but we had assembled around 1 million cases from 142 countries that Stephen Johnson, writing in the Times, described as the single most accurate portrait of the virus's spread through the human population in existence. And so this data set has powered dozens of studies, including studies that we published in Science demonstrating for the first time the effect of the non-pharmaceutical interventions in the cordon sanitaire of Wuhan in China, and just recently in Nature Medicine on the effect of differences in population structure on the intensity of COVID-19 outbreaks. It's used by the RT Tracker, the RT Live system, European CDC, WHO, a variety of other organizations. And we're getting ready to go live with an initiative that we're calling Global.Health, which will be a web portal that hosts all of these data and provides an overview of the data readiness of the countries that are feeding up data. The data come in live, they get mapped against a common schema, they're stored in a cloud database in an openly accessible format, either for raw text download or integration via our APIs. And we've been working with Google.org and 12 engineers on fellowship over the past 6 months to develop this system. The team of academics kind of spans a lot of the research areas and interests, from Professor Rebecca Katz, who's leading a major effort around policy digitization of policy information and policies that have gone into effect both nationally and internationally. Caitlin Rivers at Johns Hopkins around data readiness and epidemic forecasting. John Brownstein, who's one of the pioneers in the health technology space and leads both the health map effort, COVID Near You, Flu Near You. Moritz Kramer, who's a fellow at Oxford and was one of the original founders of the data working group, as well as a COVID data working group, as well as researchers that represent data working groups and technology efforts from around the world, from the USA and Europe to Central and South America, China, Africa, in a truly international effort around data and data readiness. And we've utilized information from these data to develop some forecasting models, and this is work in collaboration with the Gates Foundation and the Institute for Disease Modeling to demonstrate that because of this key feature of COVID-19, if we're able to estimate the kinds of super spreading events that happen, we can make targeted interventions around the types of gatherings that we have to prevent. And so we're just showing you very briefly, this is generation time for infections. So you could think about multiplying this by 3 or 4 for COVID to turn this into days. Number of infections on the y-axis on a log scale, so going from 1 to 10 to 100 to 1,000 to 10,000. And then the trajectory of various outbreaks that we simulate via stochastic agent-based simulation for different household, different group sizes, from small household and office gatherings of size 10 up through parties, nursing homes and dormitories, meatpacking plants, jails, cruise ships, and then large cities. And what we want to look for is that this red dashed line is exponential growth. That's what we want to avoid. The yellow line is the median over a few hundred different simulation runs, and the blue are just representative simulations. And what you can see as the group sizes go up from 10 to 100 to 1,000 is that these blue lines are kind of falling over, meaning that the outbreak's not taking off. And then as you get up to around 1,000, the outbreak really takes hold. And this is in settings where we don't have a heavy reliance on super spreading. For a more COVID-like disease, we see that well, even into the 1,000 group sizes, you're still getting quite a lot of falling off of these curves, and only in rare instances do you actually get get it taking off and becoming established. And this is consistent with the effective measures that many countries, Vietnam, Thailand, Mongolia, Senegal, Singapore, Taiwan, Japan, China, have deployed effectively to prevent COVID from becoming established. And what we would calculate is that secondary infections that lead to around 10 new individuals becoming infected are the critical point at which COVID becomes out of hand. And depending on what we think the secondary attack rate is, and that's going to vary by setting, vary by the kind of environment that an individual finds them in, you need to block gathering somewhere between 10 and 50 or 100 individuals from happening. That once you have too many of those is when you really start to get establishment of the disease. And we see this anecdotally in places like Sweden that don't have lockdowns, but they do have fairly strict limits on gathering sizes and also quite small average household sizes. And so what we're then trying to do is to leverage models like the one I showed you, where we have specific policy recommendations around gathering sizes. We're also working on methodologies to understand the effects of mixed policies that are implemented over space and the resulting mobility patterns that can actually drive increased COVID transmission. So the analogy, and we see this playing out all over the United States, is that if houses of worship or parks or gyms are open in my neighboring county, I become much more likely to travel to my neighboring county to obtain those services, and that can touch off super spreading events. And so, for example, one of the things that seems to be working in Vermont is that they actually have many more facilities that are open at lower levels uniformly across the state, as opposed to places like California, where you get this clustering of things that are open kind of in a sea or desert of things that are closed, and you end up with these interregional aggregation events at a religious service, at a gym, larger gym, or at parks that can then touch off these super spreading events. So what we want to do is layer the technology stack that we've built to bring in standardized individual level anonymized data that contains a much richer set of metadata, including times that individuals test PCR positive, the time that they're symptom positive, potential outcomes for individuals, geographic location, with information on policy decisions, with information on mobility, to allow for improved smart decision making around COVID-19 interventions, especially as we start to move into the spring and are going to need to expertly deploy synergistic non-pharmaceutical interventions and likely limited vaccines, or vaccines with limited efficacy, to try and return to a new normal much sooner than we could with vaccines alone. And in addition, and I think this is one of the things that came up during this conversation, right now it's fairly easy to diagnose COVID-19 with lots of fairly coarse symptom data because it's one of the few pathogens that's causing lots of illness right now. But as we start to move into a new normal, we will have to deal with COVID flare-ups, but COVID will become increasingly rare, meaning we will need increasingly large, high-resolution and granular data sets if we're going to have appropriate situational awareness to both power our machine learning and forecasting models, but also to inform decision makers from the hospital levels all the way up to city, state, county, and national levels around these different flare-ups. So now is really the time that we need to be preparing these data systems to move into a new normal, hopefully by late spring, early summer of 2021, where we're going to need a lot more specific information that can disentangle COVID from influenza, from RSV, from other non-COVID coronaviruses, so that we're able to rapidly deploy resources to prevent a super spreading event from taking hold and growing exponentially, or ideally to prevent a handful of cases that show up via travel from sparking any secondary infections at all. So with that, I would like to again thank the organizers for having me, the other panelists for what was a very exciting and informative conversation. And assuming there's time, I'm happy to take questions. Thank you.
Definitely. I know I've got questions. Others? If you guys want to take yourself off mute. Can you go back to the slide where you were talking about the RO and the number of people that are infected, and you were talking about how it doesn't act influenza. Can you talk a little bit more about that and why we think that is, and why that makes it, I guess, a challenge to kind of do predictive modeling here. You said it can either, yeah, thanks.
Yeah, so I didn't actually show you this slide. So
okay.
This to me, and there's actually a great Atlantic piece that just came out a couple of days ago about super spreading and why super spreading for COVID kind of breaks all of our brains, but also breaks a lot of the Western public health and pandemic preparedness models that are heavily based on either influenza that we basically can't stop until there's a vaccine, but there's a very clear roadmap to a vaccine, and we have plans like school closure and things to mitigate ventilators, et cetera, or Ebola and SARS that we will be able to almost certainly stop with symptom-based screening and other kinds of protocols. And COVID seems to be sitting right in this kind of sweet spot where it's pretty heavily reliant on super spreading events, but not as much as SARS and Ebola. And we know that you have this pre-symptomatic transmission, which means a high proportion, as you pointed out, a third of individuals are going to slip through, even setting aside the fully asymptomatic individuals, but the pre-symptomatic individuals that will slip through the symptom-based screening and can transmit before they have symptoms. And so what I'm showing here is the proportion of individuals that are susceptible that we would predict would get infected at the end of an epidemic, assuming there's no interventions, just based on the social network properties and the contagiousness of the pathogen. Estimated in red, discounting the effects of super spreading and just focusing on the average. In blue is using data on the effect of super spreading to basically modulate that risk, because one of the things that super spreading does is increase the probability that an outbreak chain will go extinct on its own, just because if most everybody's giving it to 0 people, then you imagine you're just kind of waiting around for one of these super spreading events to happen. And if it doesn't happen, then the infection just dies out kind of naturally. And then the X's are the best estimates we can pull from the literature from serosurveys of what percentage of individuals actually get infected. So for smallpox, towards the end of the eradication campaign, the WHO is very closely monitoring, say, villages in rural Pakistan that have essentially 0 vaccination coverage, and they can track exactly what proportion of individuals are still naturally susceptible, and then smallpox shows up and they can track the effect of the there's a bunch of estimates like this: 1918 flu, 2009 pandemic in the first wave before we had the vaccines. But what's most important is that for pretty much all these pathogens, the blue and the red are really overlapping a lot with each other, which means that, like, you know, the super spreading matters, but like if you don't pay attention to it, you can probably still do an okay job of deploying policies to intervene. But for COVID, there's this massive separation where if it's flu-like and you're on, you're on a naval vessel and you're in a highly mixed population, the types of interventions that are going to work once it becomes established are vastly different than if you're in a setting where you're trying to prevent local introductions from sparking, a global epidemic. Or you're in a case of Japan where you're engaged in these like highly active retrospective case investigation and cluster busting to prevent the super spreading events from sparking enough transmission chains that you start to get this deterministic set of transmission. And so this is why we think that the policy data and the individual level data, the mobility data, are so critical, because which of these two regimes you're in changes the policy landscape dramatically, and the amount of effort required to push a geographic location back over to the left once it becomes established, as we've seen in the US, is pretty tremendous, but it can be done. And that's why we're arguing that once the vaccines become available, there's going to be a lot more that we can do, especially in the US, to bring that viral load down and then deploy the kinds of strategies that will work when we're in that kind of blue regime.
Mm-hmm. That is so fascinating. Wow.
Also, probably a longer answer to your question than
no, I think
I could have given it a different way, maybe.
Incredibly interesting. Other questions? Jump in here, folks. It's also a little depressing that basically the super spreader, I mean, it feels like we're kind of out of control already. So.
Well, I was discussing this with writer for Wired Magazine a couple of hours ago, and one of the things that it's becoming kind of a running joke for me on Twitter is that I basically, every other tweet is the best time to plant a tree was 20 years ago and the second best time is today. It's all I'm ever saying. And so, like, one way to look at this is it's and there's really good scientific evidence for this now, that we probably could have kept COVID out of the United States. Like the testing we were doing focused on China on the West Coast seems to have stopped the number of transmission chains. And it's kind of impossible for me to imagine a reality right now where COVID is not in the US, or not in the US in the way that it is. But what that means, and so that's a bummer. We could look at it that way, or we could look at it as that means there is a playbook. And if we can get coordinated effort and leverage the vaccines when they come online, probably in Q1 of 2021, we can get back to a new normal much faster than we could for probably a disease like influenza or some other pathogen. We just have to have the policy playbook ready and the coordinated effort ready to go once we get those vaccines. And that's why, I mean, I think one of the powers of potentially this group is the right kinds of people are around, you know, to develop that playbook and to get it into the right hands once the vaccine is here to move rapidly.
What does that look like once the vaccine's in place? You're saying because you'll be preventing those super spreader events, or is the policy, you know, everybody wears a mask and you avoid those greater than 10 groups?
Well, if it was up to me, we'd do both of those things no matter what, because I think there's a lot of evidence that keeping the group sizes down and the mask wearing lets you have a pretty normal life otherwise, aside from, especially if the number of viral infections is down. But you imagine a situation where we vaccinate, I'm just making something up here, but you vaccinate the healthcare workers, you vaccinate essential workers, individuals that are going to be at higher risk for infection, and then reserve the balance of the vaccines for, quote, ring vaccination around super spreading events. So, right, you identify the super spreading event at a Big Lodge in Maine or the next Biogen, you do reverse contact tracing and you vaccinate around the ring to basically try and prevent those clusters from taking off. And you're just basically cluster busting with the vaccine. And these are strategies that we're developing with Dr. Larry Billion and others that we think could be deployed, you know, highly effectively, or at least it seems that way with the data. But I think these are the kinds of policy conversations that we need to be having so that, you know, we're not sitting here in March with the vaccine realizing that we don't really have a plan for what we're going to do with the vaccine until we have enough of a high efficacy vaccine to get, you know, to get back under wherever that herd immunity threshold is. And if we wait for that, it'll probably be a year or two before we're there, and it doesn't have to be.
That seems actually a little interesting. So you're actually saying you would use the vaccine around super spreading events. So you're almost like not rewarding, but if people screw up and have a super spreader event, you're going to rush and give the vaccine around it to prevent that? Is that kind of?
Well, the way that I'm thinking about it, and again, there are probably people on this call that disagree with this, but is that for lots of COVID, there are some high profile examples going on right now where there's clearly behavior that's riskier than it needs to be. But like in many cases, it's like, it's just a waiting game, right? Like if we have the universities open, you can do it safely, except for the rare super spreading event. And that's just somebody flipping a coin basically. And we see this in South Korea, right? Where like you have super spreading events and they cluster bust around them when they happen. And so with the vaccine, we can kind of do that at a slightly larger scale. And so we have things open at kind of a new normal. You're still going to have clusters that pop up because that's just the way the disease works, even if everybody's pretty much following the regulations the right way, because we're just going to get unlucky. It's a big country. We've got a lot of dense populations, et cetera, et cetera. And then we use the vaccine to basically keep things back in check when they happen. And so hopefully we won't be rewarding too much bad behavior. We'll get the good behavior and we'll be protecting people from the bad luck. But yeah, we do have a lot of bad behavior that we have to course correct, and hopefully the vaccine will help us do that to a certain extent, and then we can, you know, use the rest of this to get us all the way back to where I think we'd all.
So you guys, in terms of your policy that you're mulling over right now, aren't like imagining this as a massive rollout of a vaccine to everybody. It's more.
I mean, individuals on the call may know more than I do. I suspect that we will not have enough vaccine, and it will not be high enough efficacy to get us into a herd immunity situation. And herd immunity also, of course, as many people on the call understand, doesn't mean what a lot of people think it means. It's like when the fraction of susceptibles have moved into a recovered vaccinated class such that the effective R is 1, which means you can still have a whole second half of the outbreak. You can still have giant clusters. Like even if we're under the herd immunity threshold, we could still have big flare-ups of COVID. And that if we're using the vaccine in a smart way with smart policy interventions, we can get back to a new normal a lot faster than if we don't.
Okay, guys, I've been talking, so questions? Got a couple minutes.